Welcome back, Focus Learners. I am seriously thrilled you're joining us for this explainer today, because we are tackling a massive, incredibly high-yield topic for your microbiology exams and your clinical rotations. Consider this your official entry into Staphylococcal boot camp. Today, we're unpacking a classic tale of two bacterial brothers. On one side, we've got the highly aggressive, heavily armed Staphylococcus aureus. And on the other, its sneaky, opportunistic little sibling, the coagulase-negative staphylococci, or cons for short. Getting the differences between these two locked down is absolutely going to save you points on test day, and honestly, it'll save lives on the wards. Let's get into it.
Okay, so I want you to picture this clinical vignette. Put yourself right in the hot seat. Your patient is sick, the lab calls you up and they say, hey, we've got gram-positive cocci and grape-like clusters. This is it, the moment of truth. You know for a fact it's a staph species, but which one? Are we dealing with the notoriously destructive S. aureus, or is it one of the con species that might honestly just be a lab contaminant? Knowing exactly what your next step is, it's crucial. And that is exactly what we're going to master right now.
So here's our game plan for this explainer. 1. The lab bench showdown. 2. Weapons and virulence factors. 3. Primary infection battlegrounds. And 4. We'll meet the cons culprits.
All right, jumping right into Section 1, the lab bench showdown.
Now, take a look at how clearly these lab results paint a picture of these two totally distinct bugs. If you look over at the SS staph column, when it grows on blood agar, it creates these striking beta hemolytic golden colonies. Think of it as golden and literally blood-bursting. It also ferments mannitol, which tells us it's highly metabolically active. But then, look over at cons. They produce these small, white, non-hemolytic colonies. They don't burst red blood cells, and the vast majority of them do not ferment mannitol. But listen, there is one specific test on this table that stands head and shoulders above the rest.
Let's lean in for a serious exam tip here. Coagulase. This enzyme right here is the ultimate undisputed dividing line. S. aureus is coagulase positive. Coagulase negative Staphylococcus here, well, they're negative. So if you're reading a test question and you see gram-positive cocci in clusters, your eyes need to immediately scan that paragraph for the word coagulase. It is the definitive, absolute feature that separates the big bad S. aureus from the opportunists.
Moving fast into Section 2, weapons and virulence factors.
So S. aureus and cons have entirely different survival strategies. It's like they're playing two different sports. S. aureus has incredibly high virulence. It's heavily armed. It basically kicks the front door down, forces its way in, forms these destructive abscesses, and releases potent exotoxins that cause massive tissue damage. Cons, on the flip side, has much lower virulence. It's not kicking down any doors. Instead, it's a total opportunist. It waits patiently for us to breach the body's defenses, and then it relies on this incredibly sneaky, sticky survival strategy, biofilm production. But let's zoom in on one specific, insanely high-yield weapon that's unique to S. aureus, because this perfectly illustrates why it's so hard for our bodies to clear it. I'm talking about protein A. S. aureus expresses protein A right on its surface. Now, under normal circumstances, our IgG antibodies bind to a bug with their variable region, and they leave their Fc tail exposed. It acts like a flag signaling our immune cells to come over and eat it. That's opsonophagocytosis. But protein A completely flips the script. It binds directly to the Fc region of the IgG antibody itself. It literally puts the antibody on backward. This severely decreases opsonophagocytosis and effectively prevents immune clearance. Seriously, burn this mechanism into your brain. Test writers absolutely love it.
All right, Part 3, primary infection battlegrounds.
The absolute most crucial thing to understand here is this fundamental dichotomy. S. aureus destroys your native tissue, whereas con S prefers foreign material. S. aureus is the most common cause of septic arthritis in your native God-given joints. It attacks native heart valves. It attacks healthy skin. Con S, however, is a master colonizer of the foreign plastic and metal that modern medicine places inside the body.
Let's just drill this list into our heads right now. When you think of cons, you absolutely must think of prosthetic devices. Remember that sticky polysaccharide biofilm we just talked about? Well, that allows it to coat prosthetic heart valves, prosthetic joints, vascular grafts, intravenous catheters, and central nervous system shunts. Cons is without a doubt the absolute master of nosocomial device-related infections.
Okay, pause for a second because I need to give you a massive clinical warning. When a blood culture comes back positive for cones, up to 80% of the time it is not a true infection. There's no way. It's just a contaminant. You see, cones lives naturally on our skin, so if the skin isn't perfectly prepped before a blood draw, the cones from the patient's skin, or honestly even the phlebotomist's hands, gets right into the bottle and grows. Only about 10 to 20% of these positive cultures actually represent true bacteremia.
So how do you, as an astute clinician, prove that a Cons culture is an actual bloodstream infection and not just some lab contaminant? Well, you use this exact checklist. First, the patient actually has to be sick. They need a fever or localized signs of infection, plus an elevated white blood cell count. But crucially, you need to see the exact same bacterial strain growing in multiple separate blood culture draws. The growth should happen fast, usually within 48 hours, and it should pop up in both the aerobic and the anaerobic bottles. If you don't have this solid evidence, you are very likely just looking at a sneaky contaminant.
And finally, Section 4. Let's actually meet the Cons culprits. Guys, I want you to burn this massive, unmissable buzzword into your visual memory right now. Novobiosin resistant. If you're reading a clinical scenario about a coagulase-negative staph, and they drop the phrase novobiosin resistant, the diagnosis is already made. Stop reading. It can literally only be one bug.
And that bug is Staphylococcus saprophyticus. Here's the classic clinical vignette you are guaranteed to see on test day. A young, otherwise healthy woman comes into the clinic with symptoms of an uncomplicated, community-acquired urinary tract infection. S. saprophyticus is the second most common cause of UTI in this exact demographic, sitting right behind E. coli. So, young woman, UTI, coagulase negative, novobiosin resistant, boom, you've got the point.
So what about the other Cons culprits? Well, S. epidermidis is the most common one we see. It's that classic biofilm producer we mentioned earlier that targets prosthetics and catheters. But I really want to draw your attention to S. lugdunensis over on the right. Because this guy is the exception to the rule. Even though it is coagulase negative, S. lugdunensis is highly virulent. Actually, scratch that, it acts a lot more like S. aureus. It produces clumping factor, it causes rapid destruction of native heart valves, and it carries a much higher mortality rate than your typical Cons. Do not let S. lugdunensis fool you, it is an absolute wolf in sheep's clothing.
Okay, let's do a quick rapid-fire review to cement all of this. You've got a young woman presenting with a UTI. The lab shows gram-positive cocci in clusters. They are coagulase negative, and they are novobiosin resistant. Who's the culprit? Yep, Staphylococcus saprophyticus. Understanding these key differences between S. aureus and Cons gives you a massive advantage on the wards. But I want to leave you with this to think about. As modern medicine relies more and more on pacemakers, joint replacements, and hardware, Cons infections are absolutely skyrocketing. If these so-called low-virulence opportunists are mastering our medical plastics, what exactly does that mean for the future of implants? Keep that in mind as you head back to the books. Thanks for joining me on this explainer, and I'll catch you next time.